We're going to get started. This is the reign of terror today, gang, by myself. Actually not, but we'll get started today. We have some laggard members that we hope they trickle in. We have some really good hearings today on some great bills. I can't wait to hear them. It's what I call the double omega bill here today. We've got two funeral home association bills we want to get to, and then we've got a real closer, and we've got a hospital bill we want to get to for a hearing. So without further ado, I think we'll get started. And we're here for a hearing on House Bill 2254, 2262, and 2261. So if you want to look along electronically or otherwise, or have a copy, you might bring those up. And if we get time, we will take final action on bills previously heard. And I think that probably is going to happen. So we hope some of our other members will join us. Some are perhaps joining us virtually. A few more are still coming in. So Representative Barker.
Thank you, Mr. Acting Chair. Could we go through with the IT and tell us who's on virtual members?
Yeah, we'll just do a roll call real quick for your
Thank you.
edification, and then we'll go to the revisers. So first of all, present members that I have are obviously myself, Brett Parker, John Barker, Emil Berquist, Susie Carlson, Ron Ellis, Christina Hesswood, Megan Lynn, Carl Turner, and then a couple of other drifted in. Broderick's here, and then Susan Ruiz is here, and Jim Kelly, of course. I don't know why I didn't have you down. And Doug Black's back there being so quiet. So I'm missing Adam Smith and Elizabeth, and he's on virtually, okay? And then what about Elizabeth Bishop? Is she on virtually? And then what about Representative Arnberger? Does anybody know her whereabouts? Is she on electronically or virtually on WebEx? Anybody else have an accounting of Representative Arnberger?
This morning she was in Great Bend on her way in, but I'm not sure.
Well, we hope that's going okay if she gets here. But so we do have an accounting of more than adequate for a quorum, so we can begin. Any other business to come before us before we turn it over to the reviser? Seeing none, we'll go then according to our chairwoman's agenda, and she will be joining us shortly. She's elsewhere at the moment, but she'll be here shortly. So we'll turn it over to the reviser to give us an outline of House Bill 2254.
Thank you, Mr. Chairman, and good afternoon, committee.
Yeah, thank you.
House Bill 2254 is a bill concerning funeral arrangements. Current law provides that for prearranged funeral agreements, the purchaser has the option to make the agreements irrevocable up to $7,000. The bill would remove that cap so they could be made irrevocable up to any amount of the purchaser's choosing. I'd be happy to stand for questions.
Committee, you've heard the brief discussion and presentation of House Bill 2254. Are there any questions for the reviser for clarification or background information? Seeing none, I think we'll move right into testimony then. And our most important testifier today is Pam Scott from the Executive Director of the Kansas Funeral Directors Association. So, Pam, welcome to committee, and we'll look forward to your testimony.
Sorry about that. I am Pam Scott. Thank you for the opportunity to testify today in support of House Bill 2254, which was introduced at our request. Prearranged funeral agreements are entered into to prepay and pre-finance funerals by families to take the burden off them at time of need, and also oftentimes to spend down their assets when they're going on Medicaid and becoming eligible for nursing home coverage under Medicaid. About every 6 years, we would come back to you and ask for an increase in the amount of funds that can be placed into an irrevocable prearranged funeral agreement. We haven't done that for 10 years, so we felt like it was time when we were looking at this. in reviewing it, we thought, well, maybe we come in and just ask, so we don't have to come back every 6 years, to eliminate the dollar amount, to eliminate any dollar limits that are on what can be placed into an irrevocable funeral agreement. Now, if you look, the last time this was changed is in 2010, and since then, if you would apply inflation factor to that, it'd be $8,361. But we would like to just eliminate the dollar limits that are in place now. A majority of states across the country do not have any caps on the amount that can be placed on prearranged funeral agreements. Now, when someone enters into a prearranged funeral agreement, they pre-finance that for many ways. It can be through a trust, it can be through a CD, insurance policies. But the amount that's placed into a prearranged funeral agreement is generally the cost of the funeral. They go in, pre-plan, and the funeral home will give them a statement of goods and funeral goods and services will say how much their funeral will cost. And so the amount that's actually placed into these accounts is the cost of the funeral. Now, I said a lot of states don't have that, but one of the reasons this is a positive thing is because if there are any excess funds in these accounts after the funeral is paid for, any excess proceeds will be paid to the estate recovery unit of the state of Kansas. So say someone goes into a nursing home, a lot of times they'll, put the money toward the funeral if they have any excess funds they need to get rid of to be eligible. If they don't spend that entire amount, say the family after the fact decides, well, they don't want a full funeral and casket and burial, they want a cremation, then any excess funds would either go back to the estate of the deceased, or if they had received medical assistance, it would go back to the state. It's also easier for when someone applies for assistance, it's easier for the caseworkers around the state to really determine if it's been set up correctly. So they don't have to look at, okay, the $7,000 includes what, and then also the casket is how much, but they can just make sure it's financed for the dollar amount of the prearranged funeral agreement. So we would respectfully ask that you support this, and I'd be happy to answer any questions.
Very good. Pam, thank you so much for your testimony. We do appreciate it. We have no other proponents at this time and no written proponents, so we just have Pam, and so it's time to ask questions, and I can see that Representative Ellis has a burning question, so we'll turn it over to Representative Ellis for a question.
Where do you set up this fund? Thank you, Mr. Chairman, Vice Chair, whatever. Where do you set this fund up, in a bank?
Well, a family or someone will go into the funeral home, prearrange the funeral, and then the funeral director usually assists with that. Depending on the funeral home, you may have different ways you can do it. He may set up, if you want it set up in a certificate of deposit in a bank. Okay. We have a trust that our members can use for their families, whereby they can put the money in a trust fund, and it is administered by a bank, commingled funds.
Can it be paid all at once, or is there like several payments?
It can be either way. Generally, most of them are lump sum payments. Someone's trying to, spend down their assets to get on assistance. They'll have a certain dollar amount. Sometimes insurance policies are assigned for that too, if you have a pre-existing policy, so someone doesn't have to cash out the policy.
Thank you.
I believe Representative Barker's next with his question.
Thank you. And if I recall, I think these limits were put on because they used the average cost of an average funeral. Do you have any data that shows what the average cost of a funeral is today?
Well, our National Association does some studies on that. The last that they have is 2019, and the average cost of an adult funeral with a casket is $7,640. That's the average. So, some have more than that, some have less. That does not include a vault, cemetery expenses, cash advance items. You have some cases where someone may die one place, you have to have the body transported somewhere else for funeral and burial if someone dies away from home or something like that. So sometimes if someone knows someone's in a nursing home somewhere, but they want to go somewhere else and be buried with the rest of their family, then that can be included also.
One follow-up. Thank you. So right now we have a limit. We've always, I believe, had a limit, and it's been raised, as you indicated, over the years. So instead of doing away with all the limits, what would be a reasonable amount? Would $10,000 be a reasonable amount that would probably take you for another 6 years or 10 years? Or I don't know what the cost of a funeral goes up every year, but I'm sure it does.
Yeah. I mean, obviously 10,000 plus the retail price of casket, vault, and urn would be reasonable, so we wouldn't have to come in every year. But it's not like the funeral home's going to keep any of this excess money if they don't spend it. It'll go back to the state, which, I guess would be a revenue generator for the state recovery unit. One thing, a lot of times people have a $20,000 life insurance policy they have. If they have to cash it totally out, then the insurance company gets the excess benefit to that, and they may get like 50 cents on the dollar for that policy, depending how long it's been in effect. So I was always kind of an advocate. It would be good for the state if they, allowed, I mean, right now you can do it for the amount of the prearranged funeral agreement, but rather than have that policy go to waste, it would be nice in some instances if they could keep that in place, then the state would get the excess amount of whatever the dollar value of that policy is.
Well, can't they reassign as a beneficiary the funeral home if they have a $20,000 life insurance?
They can assign it to the funeral home. However, when the caseworker for Medicaid or Department of Children and Families look at it, if it doesn't match up to the prearranged funeral agreement, they won't consider it an exempt asset.
Oh, okay. I didn't know that.
Yeah.
Thank you.
I think next we have Representative Berquist for a question.
So thank you, ma'am, for being here. So the amount that's given in the case of up to $7,000 at this point towards that future arrangement, that all goes into a locked fund. But does the funeral home benefit financially from that stability? Is that considered an asset towards the funeral home since it's a guaranteed amount? Irrevocable?
Well, it remains in the name of the policyholder in some case. It depends on what investment. The whole thought of a pre-need is you put $8,000 in if it's an $8,000 funeral, and then it'll keep pace with inflation. So the additional interest and everything stays with it. But really, Kansas is a very consumer protective state. So 100% of the funds put into a prearranged funeral agreement are still owned by the policy holder. If someone dies if someone dies and they don't use those funds, it's paid to the estate. The funeral home gets no part of a certificate of deposit or a trust until death occurs, and then they have to provide a copy of the services provided signed by the family.
That's good. And follow-up question then, the reason that the amount was given over the past few years and it's increased is so that you at least give what within that prearrangement you give what is expected to come close to covering the cost. So
today it's not.
I get you. And so why was there ever a limit put on it? Do you know?
It's way before my time.
Okay,
I mean, I've been doing this 30 years too, so.
Just one more follow-up then, and that is, my concern is whether or not someone would possibly be encouraged to prearrange a bigger funeral than what they really thought was necessary, if it was towards getting them to spend more money than what they need to, so they care for their loved one, their spouse, properly. I don't know. That's I'm not trying to create conjecture. I'm just trying to understand why we would. I'm not against changing it to open. I just wanted to know the reason why, other than convenience.
I don't know if I can answer people's intentions or anything. They
Sure.
may have $10,000 that they feel they need to spend down, and therefore, you know.
I have no problem with it. I'm just
But I can say a majority of states across the country don't have limits on the amounts
Okay.
that are out there. And I think it all goes back to the state gets any excess if they don't spend it.
thank you, ma'am.
Very good, Representative Berquist. Next is Representative Turner for a question. And remember, I'm going to disappoint the chairwoman. I told her we'd have all this all done and be ready to work bills, but we're getting bogged down and she'll be disappointed in me. Go ahead, though, Representative Turner, with your good question.
Thank you, Mr. Chairman. So I was just trying to understand, so any amount, so if I put $100,000 into this thing, which I could, right? Because there's no, does it have to be tied to a specific
It
funeral
has
plan?
to be tied to, it can't be more than what the prearranged funeral agreement
Okay.
has in it. You can't just put any dollar
So it's
amount.
not, without a cap, I mean, it has to be tied to specific services that you would provide.
Right, a family
Okay.
comes in and chooses what they want, and it
Gotcha.
has to match that.
And then, so then any excess goes back to the state, not to the estate, right?
Well,
That's
it
what I'm
goes
trying
to the
understand.
state if the person was receiving medical assistance. Now, if someone wasn't receiving medical assistance, it'd go back to the estate.
It would go back to the estate.
Yeah, but there's a law that requires the funeral home to, send it back to the state of Kansas if they are on assistance.
Okay, so to your point of somebody needing to pay down 10,000, then they would have to attach that to some very nice funeral plan, even whether that does or not. So opportunities to game this are limited only by the expensiveness of a funeral plan that you could come up with to shelter this.
Yeah, I mean, we have a trust, and the average trust that was put in 20 was 5821. I guess that's the average, because some people are trying to only have 1,000 they need to get rid of. It may not pay for the full funeral, but they need to, in order to get into a nursing home or whatever, that's the amount that they put in.
Okay, all right, thank you.
Seeing no further questions, I guess we'll ask you to stick by for the next bill. And I will just point out that we don't have any neutrals that I'm aware of, oral or verbal, and we don't have any opponents of 2254. So without further ado, then, we'll close the hearing on 2254 and move on to House Bill 2262. And for that, I would look to the reviser, Scott Abbott, for his education for us on this. Scott?
Thank you, Mr. Chairman. House Bill 2262 relates to cremation documentation requirements. The bill would primarily make two changes to current law as it governs cremation documentation requirements. The first is that current law requires a permit to cremate in order to cremate a body. In any case, the bill would change that so that such a permit would only be required if the death or the cause of death occurred in the state of Kansas, or if either of those occurred in a state where a permit to cremate is required in order to cremate a body. It would also change the requirements or the provision that allows a telefacsimile signed copy of this permit to suffice for legal purposes, and would also allow an electronic signed copy to suffice for purposes of authenticity. The second change the bill would make is to current requirements that each funeral director submit a monthly report to the Secretary of Health and Environment of the bodies that they have prepared for burial within that past month. So those are the two changes the bill would make. It would take effect on July 1 of 2021, and I'd be happy to stand for any questions on this bill.
So you've heard the discussion by the reviser on 2261. Are there any questions for the reviser on this bill? Seeing none, with that, we'll give Pam her exercise today and call her back to the microphone to give us proponent testimony on 2262.
Thank you again. This also was a bill that was introduced on behalf of the Kansas Funeral Directors Association. And really what it does is if death and cause of death occurs in another state, and that state does not require a cremation permit, then one will not be required in Kansas. It's really meant to address, where there's a border, especially the Kansas City metropolitan area, where, someone might die, have a car accident, go to a hospital in Missouri, but they're a Kansas resident, but they use a Kansas funeral home. They're served by Kansas Funeral Home or crematory. In Kansas, a cremation permit is required. In Missouri, they do not require a cremation permit. They just require a completed death certificate. So if the funeral home or family goes to a Kansas coroner and asks for them to complete a coroner's permit to cremate, that coroner has to investigate the death, even though they may have no jurisdiction. Jurisdictions generally where the death occurred, which would be like in Missouri in that kind of situation. So in this case, it would take some of the burden off, especially like the Johnson County coroner that has to spend their time investigating deaths that occurred out of state. And so they would not have to do that. It would eliminate also delays for the coroner when they have to investigate a death that's not even under their jurisdiction. So that is really the purpose behind that. And also, Kansas has gone to electronic death registration system a number of years ago, so all death records are really filed electronically. So I think the one provision is just to clarify that it can be done in that manner, even though it is done that way right now. And then the monthly reports, it used to be, right now, funeral directors have to file monthly. Vital gets all that information immediately through the electronic death registration system, so they say they have no need for it, and therefore there's no reason why we should continue to file those. So we hope you will support this legislation.
Committee, you've heard the presentation of the proponent testimony on House Bill 2262. Any questions for this testimony? Seeing none, I guess you're done. Pam, thank you very much. On this bill, I'd point out there's no neutral and there's no opponent testimony. And so with that, I would bang the gavel and say that we're done with the hearing on 2262, and I'll turn it back over to my able-bodied chairwoman who will lead us through the next bill.
Thank you, Vice Chair Epley. I appreciate that. Need that real quick.
Yes, ma'am.
All right, committee, I think what we're going to do, we're going to take things a little bit out of order here. So if there is no objection, I would propose at this time that we work House Bill 2254 and 2262, the two bills that we just heard. Is there objection?
Now, do you need a motion for suspending the rules? Okay.
Representative Ellis.
Thank you. I move to suspend the rules to vote on the bill.
Okay. Well, we can take a motion. I don't normally take motions on that, so.
Okay.
But we can.
I second.
Second.
I'm sorry.
All those in favor, aye. Opposed, no. Okay. Yeah, usually I operate it more on if there is objection to it, then we'll have that discussion. But that's fine. There's nothing wrong with what you did at all. Okay, so we're going to open up working House Bill 2254. Discussion, comments, questions?
Madam Chair.
Representative Barker.
Thank you, Madam Chair. I have no objections to working the bill. I may have an amendment that I can just do from my seat here.
Yeah, just whatever you got. What do you got?
I would my amendment was to be raised the limit to $10,000 and not make it unlimited.
Is there a second? Second by Representative Turner. Discussion on the Barker amendment.
If I may, Madam Chair, the reason I'm doing this, we've traditionally always had a limit, and normally it's always been based from my research has been based upon what the average funeral is. And it would keep somebody, as the distinguished representative had mentioned, keep you from hiring or paying for a $100,000 funeral to get your spending down so that you would qualify for medical assistance through Medicaid. And then, of course, the state may recoup that at some point in time, but they may not. I've had estates where the state had paid for a number of months in a nursing home, but they turn over to a different agency who has a contract with the state of Kansas to collect those. And it doesn't always happen. So I mean, what's wrong with putting a limit like we've always had a limit? And $10,000 I think is reasonable. She indicated what the average funeral is today. And I think the average one, not the average funeral, but the average pre-funeral was $5,500. So we're almost doubling that. And then if it needs be in another 5 to 6 years, if they want to come back in, and if any of us are still here, they can then raise that limit again. That's my argument on the amendment of $10,000. Thank you, Madam
Representative
Chair.
Kelly, on the amendment.
Thank you, Madam Chair. And a question for Representative Barker on his amendment. So what, do you know, I mean, do we know for sure that 10,000 is the average cost? I mean, we had a family funeral that I was involved in paying for, and it was not extravagant, but it was closer to 11,500, 12,000.
I'm just going on what the testimony was, what the average prepaid funeral was now was, I believe it was 5,500 or something like that.
Pam, if you'd like to step back up, you're welcome to do so.
Because I think I asked the question what the average one was, and then you told me what the national figures were, and then you indicated later in the testimony that as far as the prepaid, there were like 5,000 or something like that.
Well, the average is 7,640. Right. And I don't know that we'd have an objection. You're just talking about, instead of 7,000, putting 10,000 in there, correct?
Yes.
We were just, trying to make it easy so we wouldn't have to get back. I don't know that we have a big concern about that.
Okay. Well, I think there's always a little bit of concern when you're dealing with irrevocable trust, because that is where assets go.
Right.
Thank you. Representative Carlson.
Thank you, Madam Chair. If you'd please step back up to the mic. Thank you.
We just want to see how far you can walk today, Pam.
So if that's the average rate, okay, but then didn't you state that that does not include a vault and cemetery opening and things like that, that there are extra things?
Yes, but those are exempt separately. The 7,000 is for funeral, cash advance items. So cemetery expenses are exempt under another provision of the law, so.
And a vault as well?
Vault and outside, under the law, I don't know if I have it with me, that 7,000 plus the retail price of the casket, vault, and urn.
Okay. All right, thank you. Thank you, Madam Chair.
All right, Representative Turner.
Thank you, Madam Chairman. Yeah, I would, just speaking in support, I mean, as I listened to testimony, I guess my mind, as you heard from my questions, went to, things are always good as you intend them, but I can conceive and put together a very rich, and I just think that that gives opportunity for this to become something that it's not intended to be. And that's a place to park money just for other purposes rather than the expressed purpose of actually funding a funeral. And therefore, I would support having a limit. If 10,000 is what was amended, then I could support that. Thank you.
And the 10,000 is high enough so it hopefully won't create a problem with the field workers who are trying to determine eligibility to see how it comes right down to 7,000. Is this supposed to be included or not? So.
Representative Parker, and then Representative Haswood.
Thank you, Madam Chair. Actually, another question for Comfrey, if that's all right. Is there, I know we're asking you to estimate here, but if we move the cap to 10,000, do we have a best guess at how many years it will be before you'll have to be back asking for a raise, to raise it more?
we hadn't been here since 2010, so we have waited quite a while. And there are starting to be some problems in eligibility issues, but, who can guess what inflation's going to be? Since 10, it's been 19.45%, so.
I guess to follow up, could we safely assume that for the next couple of years, we're not going to turn around and have to do this again next year, I guess is my.
No, I think we're fine.
Thank you, Madam Chair.
Representative Hasswood.
Thank you, Madam Chair. Do you know the Kansas's national average for the funeral? And you said that you haven't asked for an increase for the past 10 years. Do you know, what was the average then? I'm just trying to figure out. I'm sorry. No.
Yeah, I don't have that with me. What
Okay,
it was 10 years ago, so.
I would just feel more comfortable if we knew the Kansas average. And I'm assuming you said it might be a little bit more, is it more pricier in the urban area or rural area or?
Cemetery costs and such are more expensive, I think, in the urban area. I'm not sure there's a real big difference in funeral expenses. I mean, there's still the same overhead for the funeral home. Sometimes it's easier for the, in a big city, they have to have a hearse, they have to have, the same things, but they have more funerals to spread that out. So I think it's pretty generally the same.
Thank you.
All right. Any further questions on the Barker amendment? All right, seeing none, Representative Barker, you may close.
Thank you, Madam. And I really appreciate the bringer of the bill that she thought this would work. With that, I move my amendment.
All those in favor of the Barker amendment, aye.
Aye.
Opposed, no. Ayes appear to have it. Ayes do have it. Motion carries. Now we're back on the bill. Representative Barker.
I'll make a motion that we pass it out favorably, as amended.
I have a motion to advance House Bill 2254 as amended to be passed out favorably, seconded by Representative Eppley. All those in favor signify by saying aye. Aye. Opposed, no. Ayes appear to have it. Ayes do have it. Motion carries. Now, House Bill 2262. We're now going to work that bill. Is there any discussions or comments on House Bill 2262? Representative Eppley.
Thank you, Madam Chair. I would like to move that we pass 2262 favorably to the floor.
Is there a second? Seconded by Representative Parker. Discussions, comments? Seeing none, all those in favor of advancing House Bill 2261 favorable for passage? 62, excuse me. I'm trying to, that's what happens when you're trying to use your bifocals at an angle. Actually, they're trifocals. That was even worse. Is advance House Bill 2262 favorably for passage. All those in favor signify by saying aye. Aye. Opposed, no. Ayes appear to have it. Ayes do have it. Motion carries. Now we're at committee, and I appreciate that because that just means less work, hopefully next week, as things might kind of crunch up on us. I'm trying to avoid us having to be here on Friday, but I can't guarantee that to anybody. Okay, now we're going to open up the hearing on House Bill 2261. So, Scott Abbott, would you like to explain this to us a little bit, please?
Certainly. Thank you, Madam Chair. House Bill 2261 is an act concerning hospitals. It would establish rural emergency hospitals as a new licensure category and provide requirements for licensure of rural emergency hospitals. The bill would define rural emergency hospital as an establishment that meets certain eligibility requirements that I'll go into more detail in a second, provides rural emergency hospital services in the facility 24 hours per day by maintaining an emergency department that's staffed 24 hours per day, 7 days per week with a physician, nurse practitioner, clinical nurse specialist, or a physician assistant, and has a transfer agreement in effect with a level 1 or level 2 trauma center, as well as other requirements that KDHE might find necessary in the interest of health and safety. The bill would, for eligibility requirements for a facility to qualify as a rural emergency hospital, would provide that such a facility, as of December 27th of 2020, had to be a licensed critical access hospital, a general hospital with not more than 50 licensed beds located in a county in a rural area, as defined by the Federal Social Security Act, or it had to be a general hospital with not more than 50 licensed beds deemed as being in a rural area. So the bill would establish the licensure procedure for a rural emergency hospital to apply and receive licensure from KDHE, as well as impose some requirements on the operation of a rural emergency hospital, including not having inpatient beds, except for a separate and distinct part of the hospital, licensed as a skilled nursing facility to provide post-hospital extended care services. Would make allowances for a rural emergency hospital to own and operate an entity that provides ambulance services, as well as provide that for a hospital that receives licensure as a rural emergency hospital, if it was a general hospital or critical access hospital already, could retain that old licensure status on an inactive basis while the rural emergency hospital license is in effect. Would also make provisions for all rural emergency hospitals, including those operated by cities, counties, hospital districts, or other governmental or quasi-governmental entities, to be able to enter into contracts required to be eligible for federal reimbursement as a rural emergency hospital for the services it provides. The bill would also make a carve out for these rural emergency hospital entities to not be subject to state or federal antitrust laws while acting as a rural emergency hospital, including those contracts and agreements with hospital or with ambulance services or for other related services. The bill would also require that insurance cover services performed by a rural emergency hospital if those services would be covered under the health insurance plan if it were performed by a general hospital or a critical access hospital. The bill would also make some conforming amendments to current hospital licensure laws. It would give KDHE latitude in adopting rules and regulations for licensure of medical care facilities, as they already have authority to do. It would also allow them to consider requirements for a facility to receive federal reimbursement as they adopt those rules and regulations. It would also provide that the licensure requirements for a hospital would be deemed satisfied by a rural emergency hospital if the hospital meets the licensing requirements established by KDHE in accordance with this bill. The bill would take effect on July 1 of 2021, and I would be happy to stand for any questions.
For Revisor Abbott, Representative Epley.
Thank you, Madam Chair. And I just wanted to get clarity on the bill. On page 2, on 2 lines, it mentions, and it's just kind of nitpicky, critical access hospitals are 25 beds by statute in the state, and I think nationally, and yet it mentions 50 beds licensed. And is that inconsistent, or am I just overreading that, or?
So Representative Epley, could I specify, are you talking on lines like 19 through 25 on page 2?
Yes.
So the 50 bed limit is under the general hospital criteria. So if a general hospital is trying to become a rural emergency hospital, the general hospital can have not more than 50 beds. There's no specificity in that paragraph 1 on line 19 for critical access hospitals for the reasons you specified, I believe, because that's already handled in kind of the base licensure of a critical access hospital. So there's no need to specify that here.
Okay, thank you.
Further questions for Revisor Abbott? All right, seeing none, thank you, Scott, appreciate it. All right, our first proponent that we have today is Tara Mays, Vice President, State Legislative Relations with Kansas Hospital Association. Welcome to committee, Tara.
Thank you so much, Madam Chair. Appreciate the opportunity to appear before you to testify in support of House Bill 2261. I am Tara Mays with the Kansas Hospital Association. I want to appear before you today in support of this bill on behalf of our 122 member hospitals to support this very important piece of legislation. As you all are probably very well aware, hospitals in rural parts of our state face many, many unique challenges right now. Whether that's stemming from evolving demographics in their communities, from reimbursement reinductions, or from heavy regulatory burdens that can contribute to added costs. We know that our rural hospitals are facing tough challenges that require the kind of perseverance and innovation that can only come from our state's very unique and highly talented rural communities. We know that these financial losses, for all of those reasons that I mentioned before, have placed a heavy burden on our state's struggling hospitals. And just like a lot of our rural Kansans, our hospitals take quite seriously their responsibility to provide core infrastructure services to the communities that they serve. It's in that spirit that keeps our hospitals committed to keeping their doors open and serving their patients in the right ways at the right times, no matter the challenges, whether that's financial challenges or otherwise. And I think we've seen that especially over the course of the last year. Our hospitals have been seeking new ways to ensure that they can provide the quality of care that our rural Kansans continue to count on. One way that we at the KHA have been assisting our member hospitals is by developing an alternative rural health model. In the past, you've probably heard the Hospital Association talk about it as a primary health center model. It is now codified in federal statute, and that is very similar to the structure, but is now called the Rural Emergency Hospital Model, which is what is in the bill before you today. This model really does provide a sustainable option for our rural communities to provide an emphasis on the care that is most desired and accessed in the communities throughout rural Kansas. The services that are really focused on preventative and primary care, on chronic disease management, and emergency medical services that Kansans continue to count on. The rural emergency hospital model allows for our local hospitals to serve as access points to coordinate overall care levels if higher levels of care from a regional perspective are warranted. It's important for the committee to not only understand what I think Mr. Abbott explained that this bill does, but also what it doesn't do. The rural emergency hospital model that's before you today does not require any of our hospitals to change what they are doing right now. It just allows our hospitals to opt in if this is a tool and one that is right for their community. This bill also does not prevent a hospital from implementing a new model or returning to a former designation as a critical access hospital. The model is not prescriptive in that additional services that might be right in any particular given community can still be coordinated with the rural emergency hospital model. After many years working with our Kansas federal delegation, we are quite pleased to inform you that as of December of 2020, the version of the CARES Act that passed Congress did create the federal model that is before you today. And that federal legislation requires that our state statutes are in alignment to be able to implement this new payment and delivery model. This is really now is the time to build on that work that KHA has done to ensure that our Kansas hospitals don't get left behind, and to allow those that are interested in this option to take advantage of this one tool that could be available in their tool belt to be able to keep them sustainable over years to come. The rural model is one that KHA has done a lot of work on, as I mentioned, and I have with me today Jennifer Finley, who is the Vice President of Education and Special Projects with the KHA, to talk to you a little bit more about what KHA has done on that model. Madam Chair, if you'd like, I'd be happy to turn it over to her, and I'd be happy to stand for questions at the appropriate time.
Okay, and you can turn it over to whomever you want, but the chair will decide.
Of course.
Okay, I'll recognize Jennifer Finley, Vice President of Education, Special Projects, Kansas Hospital Association. Thank you very much, Tara.
Thank you. Good afternoon,
We all
everyone.
learn as we go through this, Tara.
Can you hear me?
Yes.
Okay, good afternoon, and thank you for allowing me to spend a few minutes talking to you. As Tara indicated, this is a project that we have been working on with our member hospitals since 2012, and we're very excited to see that we're near the finish line of something that really truly has become a Kansas-based solution, something that we think a number of our small rural communities will find to be a viable solution for them. As Tara said, we're not advocating that every hospital in the state change to this new model, but we do know from some preliminary research that we have done that approximately 75% of the patients that visit many of our small rural facilities would still continue to be served under this new approach. I know there was a question just a moment ago about some of the language specifically contained in the bill, and I wanted to let you know that that language was crafted to mirror the federal legislation that was passed in December. So the definition of what a small rural hospital is was established at the federal level, and we're simply following those same pieces than of definition. I'd be happy to provide you with a list of hospitals that would be eligible if that's something that would be useful to you at a later time. We're just, as I said, really excited that we're going to be able to start helping our communities prepare those that might be interested. And as part of this continuing work that we've been doing across the state, we have been partnering with the Kansas Health Foundation and the United Methodist Health Ministry Fund to hold a series of virtual regional conversations across our state. We started those 2 weeks ago and we'll continue them through March. And the purpose behind these conversations is really to just engage folks in what's happening in our rural health delivery system and talk to them about some of the options that might be available to communities should they desire to make a change at some point in time. We certainly want to make sure that we're preserving access to healthcare services for all rural residents, and this is just another way that we can do that. Like Tara, I'd be happy to answer any questions that you might have.
All right, thank you very much. Appreciate it, Jennifer. Next, I have Larry Van Der Wedge, Administrator of Lindsborg Community Hospital. Welcome to committee.
Thank you, Madam Chair. I'm the administrator, she said, of Lindsborg Community Hospital. I entered healthcare as a physical therapist in 1996 and worked into administration in the mid-2000s and became the administrator CEO in January of 2008. I'm honored and appreciate the opportunity to provide written testimony and comments in support of House Bill 2261, which creates the Rural Emergency Hospital for our state. I think if you ask my managers or medical staff members what is a common phrase that I use when working on problems, they would say I often ask, what are our options? Having options is key to finding solutions. Dwindling options is what led the Kansas Hospital Association to form the working group to work on rural health visioning. Unfortunately, the changing landscape of local demographics, along with the reforming delivery of healthcare, created challenges that the usual advocacy and tactical efforts cannot overcome. Our work group tried to erase from our minds, to the degree possible, healthcare delivery as we know it. We started with a blank canvas and said, if we were to create a healthcare organization for rural Kansas, what would it look like and how would it be funded? Quite often, individuals and organizations just want to sit and wait for government or some other entity to provide a solution. I'm proud of the KHA and our working group because we decided to help develop a solution, not just complain about the problem. The need for a new model is not unique to Kansas. Throughout its development, and especially after the white paper was completed, hospitals and state organizations throughout the country expressed interest and intrigue in our work. So current options for CEOs like me include staying as a prospective payment hospital or critical access hospital, even when inpatient volumes don't justify the expense of inpatient beds, or becoming a freestanding emergency department or urgent care clinic, or becoming just a clinic or federally qualified health center. Each has its own benefits, but also limitations, especially for a community trying to provide the needed health services to try and maintain the health and vitality of its rural community. Becoming part of a system is also an option for many, such as the decision LCH made in 2012 to become part of Salina Regional Health Center. At the same time, not every larger facility or smaller facility is willing to form an affiliation with each other. And even if that is the case, the smaller facility needs to be financially viable. So I believe strongly that the Rural Emergency Hospital is the new option needed, not for all, and possibly only a few, but needed nonetheless. It would enable a struggling hospital to shed the expense of maintaining unneeded acute care beds while maintaining what is needed most. This includes primary care providers, emergency and possibly urgent care, lab, radiology, rehab, and other necessary ancillary services. It would require transfer agreements with larger nearby facilities and a robust EMS for life-saving transport. Post-acute beds would also be allowed for the often necessary rehab for a patient returning from the tertiary hospital. I realize the financial reimbursement of the Rural Emergency Hospital is still in development, but our anticipation is that it will provide a budgeted block-type payment that provides stable monthly cash flow and take into account quality and volume. It also must achieve the triple aim of reduced cost to the overall healthcare system, provide high-quality healthcare while maintaining or even expanding access to the citizens of Kansas. Anything less is not acceptable. Rural hospital boards, administrations, and medical staffs need options to meet today's challenges. House Bill 2261 gives them a much-needed option for some. Thank you for your consideration and hopefully support of the rural emergency hospital. Thank you.
Thank you very much. Next, we have Chris Matthews, Chief Operations Officer of Decatur Health. Welcome to committee.
Thank you, Madam Chair, for your time. I appreciate it. We had the opportunity to partner with Kansas Hospital Association last year when they went out to communities. Oberlin is about 1,500 in population, and we are a critical access hospital. We're licensed for 18 beds. We have an emergency department, primary care clinic. We have rehab and lab and diagnostics as well. Going out to the public and talking to them about what would it look like for the primary health center model or this rural emergency hospital, nonetheless, was a little scary. Not only for me as an administrator to go out to talk about this new model, and to see what the community would say about this model for them. We got them all in a room. About 80 people showed up to this event, and small groups, and got them engaged with discussions about what they really needed for their health. And throughout the end of the night, they found out that even though we were licensed for 18 beds, having only one patient per day in acute and then 2 patients per day in the skilled nursing facility probably isn't what they're going to be needing, isn't nearly as important to their health as they probably once realized. We've been partnering with a hospital just north of us here for a while, and having a transfer agreement and having a partnership with them is something that healthcare has kind of already started trending. Part of a accountable care organization as well really gets the care out into the community beyond the hospital. It's a proactive care nowadays anymore that we've put a lot of time and effort into keeping patients healthy, and we're into the prevention and wellness, and it keeps them out of the acute care. So having a designation for a rural emergency hospital is one of the things that could work in a community of our size. Thank you, Madam Chair.
Thank you very much. Were there any other proponents that I did not call that thought they were on the list? All right, seeing none, committee, you will note that you have written testimony from Senator Jerry Moran, Rochelle Colombo with Executive Director of the Kansas Medical Society, Jay Hall, Legislative Policy Director and General Counsel for the Kansas Association of Counties, David Jordan, President and CEO of United Methodist Health Ministry Fund, John Donnelly, Kansas Farm Bureau, Wendy Stark, Research Associate, the League of Kansas Municipalities, Vicki Whitaker, Executive Director, Kansas Association of Osteopathic Medicine, and Alex Orrell, Senior Vice President for Governmental Affairs, Kansas Bakers Associations. Are there questions on the bill? There were no opponents. Representative Kelly.
Thank you, Madam Chair. And this could be for Tara, I'm not sure, but as I read through this earlier and heard the discussion today, of course, in 2015, Independence was the first community to lose their hospital. Since that time, Labette Health has come in and put what sounds exactly like this. They put in an emergency room with a clinic and a couple of observation beds to decide whether someone may need to be transferred. So that would have been a ground-up one. Does this legislation only deal with someone a community that has a hospital and they want to convert it back, or can this be a ground-up build in a community that's potentially lost the hospital and then a way to restart?
Tara?
I think that's a really great question, Representative Kelly. I do the way that the bill is defined and written right now, it appears that it would have to be an existing hospital or hospital facility that would need to be a real emergency hospital. I think it would, and I will let other conferees correct me if I am wrong, but I do think it would have to be an existing facility.
This is Jennifer, and I can add some clarity. The federal legislation that was passed in December provided guidance, and it did not address an existing or a hospital reopening under this category. It is certainly something that we are interested in, and we'll be talking to CMS as they further develop rules and regs, and hope that we might be able to offer this option up to some recently closed hospitals. But the way that the federal legislation is written, we cannot do that at this time.
One more. So when you're looking at that, I mean, in Independence, the hospital that was closed was not used, you may be aware, wasn't used to put this type of facility in, but it was a ground-up build. So that may be, if you investigate that, you might look at both options. I mean, that the existing facility was too cost-intensive to do, and you could come from the ground up and convert it much easier and have the operations much leaner that way.
Yeah, I know that there is some concern about not creating even more facilities across the United States. And that was part of the reason they took that approach. But I do think in specific instances in which communities had recently closed facilities, there should be some lenience given, and we will certainly be passing that message on.
Representative Black.
Thank you, Madam Chair. This question would be for Tara. How would this work in terms of the actual nuts and bolts? Would because some of the hospitals have some public ownership, would the hospital board get together and agree on that? Would they have to have a public meeting? Would they, have to involve, how would that just process involve? Could you help me out on that?
Yeah, I think that's a really good question, Representative. Of course, as we mentioned today, the Hospital Association has been working with some of the hospitals to have and do some of that community outreach at the outset. But yes, it would require some additional kind of community engagement. And I do think it would a lot of times require, beyond just the board itself of the hospital, a lot of kind of deeper community engagement. So yes, there would be kind of several layers of that. Jennifer, I don't know if you have anything to add there.
Sure, I do. The federal legislation specifically outlines that a facility that would want to convert must put together a transformation plan, and they outline some of the components that that transformation plan must contain. And part of that process is a public dialogue, but ultimately this would be under the governance responsibilities of that board and or any other boards associated with the hospital to make the final decision.
Thank you, Madam Chair. If I can have a follow-up, maybe it's more of a comment. I said 5 years ago that even a motel with 10% occupancy can't survive. And we're really seeing a lot of that. Now, I'm from Independence, was born in that hospital that was closed, and it was a severe blow. We lost 190 good-paying jobs. And I would like to have seen, the bed health, what I affectionately call the transfer station, is really working pretty good. And I think we're going to have to go to a regional concept like this to where, having $4 million imaging equipment in one hospital 10 miles apart is not good a business model when we're so mobile and I can drive 20 miles to even a better hospital, so to speak. So I think this is much needed. I completely support it. I think it's a good concept and really for the rural areas like my district, particularly, we need something like this. I appreciate the hospital going forward about this innovation, and I'm in 100% support for it. Thank you, Madam Chair.
Representative Epley.
Thank you, Madam Chair. Didn't mean to choke you up. This is for Ms. Finley. And I'm just kind of adding on to what Representative Kelly mentioned. Our hospital recently took over a facility in Horton that closed, and I think we really need to plead for a grace period of plus or minus, I guess, plus maybe 2 or 3 years for facilities that have recently closed to fall into this category, because we have, I think, 4 in Kansas that this would apply to, maybe 5. And I just think that's important. And also in the bill, and I've kept looking and I couldn't find it, these hospitals have to partner with another facility, obviously a larger facility for transfers. Is that correct?
They have to have a relationship with a trauma designated hospital, a level 1 or level 2. The way that the current critical access hospital program operates is that there is a more formal relationship with a supporting hospital, usually closer to them, that provides a variety of different kinds of support services. Those are the kinds of things that CMS will be including in their rules and regs as they start to develop how this program will operate. So we don't know yet what all of that's going to look like, but is certainly something that we think would be appropriate and consistent with past programs.
Thank you for that answer. Madam Chair, just a rhetorical response here. I just want you to, again, to understand there are at least 5 hospitals, of which Independence is one, Horton, Fort Scott, and I think maybe Oswego. They're the 4 that pop in my mind that recently closed, and technically I don't think they would fall within the realm of this bill as it's currently structured, but I think it's something that is a real strong need in those communities and would really improve access dramatically. So we'll look to you all to carry that message back to the powers that be to perhaps help us make some changes with this.
Representative Reese.
Thank you, Madam Chair. This question is for Tara. I'm curious, has law enforcement had an opinion about this? Have they voiced anything in favor, hopefully?
You know, we've had a close working relationship with law enforcement on many issues, and I'm sure they've been engaged at the community level, if not at the district meetings that we've been having, certainly at the regional meetings that we've started at the KHA. But we haven't had a specific conversation with them about this bill. You all have been keeping us quite busy.
I'm just, you know, I'm very much in favor of this bill, and I think you know, when in case of like psychiatric emergencies, sometimes before a person can be transferred to a higher level of need, you know, like a state hospital, they have to have a medical clearance. And so being able to go to a rural hospital like this would give them the ability to have that medical clearance versus them having to drive I don't know how much further in order to get that done. So I think that would save them time. Thank you.
Representative Turner.
Thank you, Chairman. Madam Chairman. Yeah, I think this question is also for Tara, but, you know, I think this is about reflagging existing facilities as a rural emergency hospital. So what would a person walking into one of those facilities today have a different experience than they would after it's reflagged?
So I think you bring up a really good question, and the primary difference would be it probably would look a lot like the services they're already getting today, with the exception of if that person were to walk in and let's just say they need emergency care, they have, you know, some kind of medical condition that they need to go to the emergency room to access care. They are going to be stabilized in that rural emergency hospital, and then they would be looking to be transferred if they were going to stay beyond that 23-hour time frame. And I don't know, I don't think it would change a lot of the nuts and bolts or mechanics in terms of when you walk into that healthcare facility, will it look or feel differently? I think it would just change the designation. I don't know, Jennifer, if you have anything that you would want to add.
I think that's a really good distinction. We're essentially, these facilities would no longer have those inpatient or overnight beds. They could still operate what we call swing beds, which are rehabilitative services, oftentimes used after a procedure. So you might leave town to have a hip replacement, but then come home for a few days and stay at a rural emergency hospital for your rehab services. And there is a provision that would allow those kinds of things to still occur. But if you reach a certain level of acuity where it's determined that you would need to have overnight care, that's when you would be transferred to another facility. And as we have mentioned, we have a number of hospitals across our state today that have only 1 or 2 patients staying in those overnight beds on a regular basis. So for those communities, this would not be a significant change at all.
Anyone else further questions? Tara, do we know how many hospitals we anticipate to participate?
I might ask Jennifer if she has a better idea, since she's been a part of those community conversations. She might have a better idea of how many have expressed interest.
Thank you.
I think we have some hospitals interested, but as you can imagine, our prior conversations were about a concept that we were hoping we could talk the federal CMS folks into giving us a shot to try. And now we have something real. So I think the perception is going to be a little bit different because now there is a true solution that communities can really start to discuss and look at. But if you look at the history of the critical access hospital program in our state, which we were one of the pioneers in getting that program off the ground, like all things, change is difficult and scary and it starts slow. So I would not anticipate we would have lots of facilities that do this as soon as it becomes available. But I think we have a few that will take a serious look at this as they start to look at their future and think about the best ways that they can deliver care.
Okay, and then if we're also, this doesn't automatically change reimbursement rates from insurance companies or Medicaid because of this new designation, does it?
It does, what the bill does say is that insurance companies would need to enter or recognize these facilities just as they recognize others. But if you're talking about a private insurance company, those are individual negotiations with hospitals, and that would remain the same under the rural emergency hospital model. We would certainly ask and expect that Medicaid would come to the table and work with us. We've had some preliminary conversations. Since this is a CMS designated model, there is some anticipation that not only Medicare, but Medicaid would reimburse these facilities. What the rate of reimbursement looks like for Medicaid, that has not been determined yet.
So it's not an automatic?
I think the details are still in the CMS rules and regs as they come out. And they may provide some direction to Medicaid programs on how they expect them to treat these facilities.
Okay, because because I'm very excited to see this bill. It's been a long time coming because we've talked about it, the changes that we need to make for our smaller communities and to save their hospitals. But when you get into talking about reimbursement rates, then we may end up having issues, and now we're not hearing that that's definitive from the federal level. So the question would become then, does that have to come from the federal level, or is that something that can be done on the state level?
I think it would be a little bit of both. And again, until we see how CMS specifically writes the rules and regs around this program, I can't give you more specifics.
Okay, thank you. Representative Epley.
Thank you, Madam Chair. And just going back to the referral hospital, because this is important to me. So if a patient would come into a rural emergency hospital at 3 o'clock in the morning with non-trauma related issues, and this hospital is in a relationship with a level 1 trauma center, but it's a non-trauma related issue, but they're not going to keep them overnight because it's a medical problem that requires hospitalization, can they be referred to a nearby critical access hospital that does have inpatient capacity?
It would be my anticipation that yes, that would be allowed. That's certainly one of those points of clarification that I think we want to make with CMS. Oftentimes we find that unfortunately they don't really still understand what rural looks like. And if we're talking about a level 1 or 2 trauma center in Kansas, there's only a handful of hospitals that meet that definition. And I'm not sure they really understand what our picture looks like. So we need to show them the practicality side of this so that we have some flexibility in how it operates.
Thank you, Madam Chair. And just to complete this, so we need to understand that the majority of patients that come in that would require hospitalization probably are non-trauma patients, and this relationship issue, if it has to be a level 1 or level 2 trauma center, is a relatively high bar and might create a barrier. And I would think there are a lot of critical access hospitals that are going to maintain their 25 level hospitalization level, and they would be very appropriate for transfer in these situations. But I don't know how the final regulations are going to look on that, and I didn't know if you had any insight on that, Jennifer. Thank you.
Committee, are there further questions on the bill? All right, seeing none, thank you very much. We appreciate everyone that was here with us today. Committee, there are no opponents and there are no, yeah, we went through the written list and there's no neutral on the bill. So that'll close the hearing on House Bill 2261. Is there objection to working House Bill 2261 today? All right, seeing none, I'll stand for a motion. Representative Epley.
Thank you again, Madam Chair. I would move that the HHS committee move this out favorably.
I have a motion to advance 2261 favorably. Seconded by, I already had a second over here, I'm sorry. Did you have a question, Ms. Representative? No. Okay. Now, Representative Kelly had already asked to second the bill. Discussion, comments? Seeing none, all those in favor of advancing House Bill 2261 favorably signify by saying aye. Aye. Opposed, no. Ayes appear to have it. Ayes do have it. Motion carries. We are recessed until tomorrow at 1. Wait a minute. What? No, that's it.